Okay, so hopefully you can see that. Yeah, you can see my screen. So today, I thought what I was going to do is talk about a pelvic floor rehab post prostatectomy, which is kind of a evolving kind of specialism, and um, something that's developing over time, and it is a big issue because there seems to be younger and younger people getting prostate cancer, and also um, then having to have prostate resections. So if we look at the risk factors in prostate cancer, the risk rises as you get older. Most cases are diagnosed in men over 50. The ethnic group, it's much more common in the black community. They need to be screening these guys a bit more to catch them early. If you have a family history there's an increased risk. If you're a brother or a father with prostate cancer before age 60, or if you have a close female relative with cancer. Obesity may be a link between that and prostate cancer, but the evidence is not absolutely clear. There's some evidence that a diet high in calcium is linked to an increased risk of developing prostate cancer, and a balanced diet with regular exercise may lower your risk. But regular exercise and a balanced diet tends to lower your risk for all morbidity. So genetics, if you have the BRCA2 mutation, have a higher lifetime risk of developing prostate cancer. If you have a BRCA1, it's only a slight increase. But BRCA1 and BRCA2 can increase your risk of being diagnosed with prostate cancer at an earlier age. So how do we look at prostate cancer? Well, abnormal cells aggregate in the prostate gland. Almost all prostate cancers are adenocarcinomas developed from the gland cells that make the prostatic fluid. There's two genetic cell types, epithelial, stromal. The epithelial cells are gland cells from secretory basal cells, and stromal cells contain smooth muscle cells and fibroblasts. Adenocarcinoma is 95% of all prostate cancer. And the grade of the tumour is important depending on where the patient is with their pathology and what their treatment is going to be. So the Gleason score is this way of measuring how advanced your cancer is. It ranges 1 to 5, describes how much cancer from biopsy looks like healthy tissue or abnormal tissue. Most cancers score a grade or higher. Prostate tumours are often made up of cancer cells that have different grades. There's two grades assigned for each patient. There's a primary grade, secondary grade, and the primary grade is given to describe cells that make up the largest area of the tumour. The secondary grade is given to describe the cells of the next largest. The Gleason score is written as 3 plus 4, and that means that most of the tumour is grade 3, and the rest of the tumour is grade 4, but your total Gleason score is 7. Cancers are made up of cells with the same score. The grade for the area is counted twice to determine. So what do Gleasons mean, basically? Typical scores with cancer patients range from 6 to 10. The higher the score, the more likely the cancer will grow and spread. Scores of 6 or less describe cancer cells that look similar to normal. So scoring a 7 means that the largest section of the tumour scored a 3 or a 4, suggesting you've got this intermediate risk. Scores of 8 or higher describe cancers that are likely to spread more rapidly, so the treatment has to be expedited. The Gleason score is useful for predicting behaviour of prostate cancer. However, there's other factors that contribute to determine the stage of the prostate cancer, and we don't get a Gleason score until we find these other initial tests positive, because this comes from a biopsy. So the first thing that usually happens is you have a physical exam of the prostate with a digital rectal exam from a doctor, urologist. They examine your perineum, the lower rectum. They use a gloved finger into the anus, and they can feel the prostate gland. As physios, it's not within our scope of practice to diagnose prostate cancers, but oftentimes if we're doing internal exams, we may come across changes in prostates that might encourage us to send our patients to doctors for a medical. There's a palpable mass, you feel enlargement of the prostate, in the size of the nodule you try to determine in centimetres, and how much nodularity is spread around the prostate. The other thing is, are there palpable lymph nodes in the inguinal area or the anterior abdominal area, which might get some kind of metabolic. So kind of the next thing we want to do is do imaging, transrectal ultrasound, MRI scan. In the UK, it tends to be MRI scan. We might do chest x-rays, maybe PET scans or imaging of the abdomen, pelvis and bony skeleton to check if that there is no metastases or spread of the cancer. The most common test here we have is prostatic acid phosphatase, which is PSA, and then we have a PSA test. Prostatic acid phosphatase tends to be elevated in those people with metastases. Prostatic specific antigen can be raised in people with cancer and without cancer, so having sex can raise your PSA, riding a bike can raise your PSA, so there's a little bit of false positives with PSA, which brings in a bit of a controversy about it again. So it's routine for men over 50 years, they're a high risk group at 40 plus years, and the PSA test reveals the presence or absence of a marker of prostate cancer. It doesn't really serve as a diagnosis. You have to have a DRE and an MRI scan and perhaps a biopsy even to find that. So levels between 4 and 10 nanograms per milliliter suggest a 25% chance of prostate cancer. And then if you go above 10, you've got about a very increased risk of 67% chance of prostate cancer being diagnosed. You're looking really for changes in PSA over time or sequential testing that can contribute to a more accurate or evident or precise, accurate estimate of the likelihood of cancer being present. So there's some controversies around PSA, and the question is, can the PSA test reduce the overall number of deaths, and whether the benefits of routine screening outweigh the risks. So screening people that are generally healthy detects prostate cancer about 6 years earlier than a DRE and 5 to 10 years before symptoms are noticed. Now, statistics show that prostate cancer mortality rate in the US is reduced by 40%, greater than 40% since the early 90s when PSA screening spread. So there's a move towards using PSA screening to detect earlier cancers despite some of its inaccuracies. So why the controversy? Because the test can detect small cancers that may never become life-threatening. The PSA leads to biopsy, and that can lead to bleeding and infection, and still have a negative finding. There's side effects of the treatment of cancer, and there's a big discussion between testing and screening. So we look at the kind of pathology, we look at cell type. When it comes back, look at Gleason score, the size of the lesion, invasion into or through the prostatic capsule, the size and number of lymph nodes involved, and the involvement of other structures like the ductus deferens, seminal vesicles, the urethra and perineum. Biopsies are kind of the gold standard to see if there's any cancer tissue in the prostate, and then we get to how we treat it really. And I think one of the main things we do here is initially, if your PSA is low and you don't have lots of nodularity prostate, then you do some watchful waiting, where we would follow you up and check over a period of time with no active treatment. A lot of guys with changes in PSA and changes in prostate nodularity don't go on to reduce cancer cells. The kind of least kind of slight invasive treatments involve hormone manipulation, radiation therapy, up to transurethral resection, where they will kind of go in and bore out some of the prostate tissue, maybe some lymph node dissection at the same time to relieve bladder outlet symptoms. So they often use that to treat benign vaginal hypertrophy. Benign prostate hypertrophy. And it's considered adequate in early stage disease. Sometimes it's a part of a diagnostic procedure to see where you sit with your PSA and maybe your Gleason score. There's different things of using laser, green light laser, cryo prostatectomy, Zoom, which is a high pressure steam system, and then do segmental resection of the prostate where the capsule remains intact. And it's kind of important if that can happen, because that saves the cavernosal nerves that sit embedded in the capsule, which are really important with regards to recovery post-operatively. And then we get right down to the bottom of the list. We have radical prostatectomy and radical robotic prostatectomy. And so radiation systemic therapy is interesting because it can be used for high grade or large or extracapsular tumours, but it can have can have quite a lot of side effects, and it can cause quite a lot of scar tissue and quite a lot of damage to tissue that isn't cancerous. Chemotherapy on top of that, and hormones are really the systemic therapy to try to reduce growth by manipulating the person's hormones. The side effects of radiation therapy are urinary frequency, urinary urgency and frequency, so going too often or having to go really quickly, problems with sexual function, bowel function, diarrhea, erectile discomfort, fatigue. And most of these disappear after treatment, but the male patients that I have that have this treatment aren't particularly happy with it. But they understand the importance of it if their cancer has spread a little bit. Again, hormone therapy, because it's driven by male sex hormones, if we can lower these hormones, it helps the slow growth of cancer. Its androgen is a testosterone, so androgen deprivation therapy. And the guys don't like this so much because it often tends to reduce their sex drive and the libido. Some of the side effects from it, because of the reduced testosterone, it makes them feel a bit upset, unhappy. As they're already unhappy because they've had a diagnosis of cancer, having this therapy can sometimes it doesn't affect them at all, and some guys have very, very little side effects from it and are quite happy to be on continuous. And then there's radical prostatectomy and the complications post-prostatectomy surgery, which are what we see. In the early days, you have things like bleeding, urinary tract infection, incontinence, stress incontinence, erectile dysfunction, narrowing of the urethra or the bladder neck, a formation of cysts, and then Peyronie's disease. And there's a high percentage of people following prostatectomy that get Peyronie's disease. There's some things I think as well. One of the things to mention here is that oftentimes the patients are upset because when they have their prostatectomy, they remove a portion of the urethra, and when they sew the non-cancerous urethra area back, they remove the prostate, they remove the urethra, they lose an inch, maybe 2 inches of the length of their penis, because the shaft of the penis is pulled tight into the abdominal cavity. And one of the things they often are quite surprised about and maybe shocked is that they wake up from surgery with a much smaller penis than they went in. So what can we help with? We can help with urinary incontinence, stress and urge, erectile dysfunction, Peyronie's disease are the three main things. So rehabilitation of urinary incontinence is kind of a real, it's not so much, I think, about focusing on the pelvic floor, but looking at the whole patient and what they want to do, how active they were before, how active they want to go back to that activity, what activities they were doing before, mountain biking, riding, skiing, they don't want to go back to sex. And so when you're looking at patients like this, you have to look at the whole patient. And the first place I usually start is their breathing strategies and how they manage their pressure system control. Are they breathing apically, lateral costally, diaphragmatically? Are they taking a deep breath? Are they taking a shallow breath? And then how does that tie in with their ability to actively contract the pelvic floor muscles, as well as ability to actually relax the pelvic floor muscles? Now, I think that when we're looking at pelvic floor muscles, in my opinion, I think the pelvic floor muscles are not mythical. They're not different to every other muscle that we see, and we need to assess the different components that muscles are able to that they have, like strength, which is maximum voluntary contraction, power, which is this rapid contraction, or this idea that you can really quickly generate force with a muscular contraction. And I think there's another kind of concept here called rate of force development, and it's the idea of how quickly you can generate that maximum rapid contraction within the first few milliseconds of demanding that from your muscle. And sometimes I feel that's a hard thing um, to rehabilitate in the pelvic floor, because oftentimes when we're asking our patients to do quick contractions, I'm not sure that we're asking them to do them quickly enough. And I'll talk a little bit about some ideas I have and how we can make sure we're getting closer or towards that concept of an, a really fast, rapid contraction that will make um, the muscle work to develop power. And then endurance, which is this ability to contract over time. So it's like you're at a much lower level of contraction, not maximum voluntary contraction. It's almost like it's working in the background. And in the case of continence, it would be where the contraction of the external urethral sphincter and the pelvic floor muscles is able to contract to a level that keeps the pressure in the urethra greater than the pressure in the bladder, and therefore the urine can't escape. So from an assessment point of view, we're looking at observed breathing strategies. We're looking at whether, where are they breathing, how are they breathing, are they taking a deep breath, or do they breathe very shallow? Do they not breathe very much? Sometimes you're talking to these guys and you might not see them breathe in 20 minutes. No, that's an exaggeration, but they seem not to be breathing at all. And when you mention it to them, they're often they'll take a big breath in, and they will um, um, and suddenly say, yeah, you're right, I'm not breathing at all. I hadn't really realised that. And partly that's they're maybe concerned about holding their core, trying to make their core rigid to help improve their continence or whatever other symptoms they're having. So when you want to observe pelvic floor muscle contraction, you can have these guys undressed, draped in your treatment room. I have a bit of I think when you're going to look at them, when you're going to assess them, I make sure that I'm not in and out of the room all the time. I stay in the room during the assessment, the initial assessment. I've got them, make sure the room's warm, comfortable, make sure you have gloves, make sure you have lube, make sure you have everything that you need in the room so you don't have to go find it. Sometimes that does happen, but you want to minimize that if you can. And with them lying on their back with their knees bent up and kind of crook lying, you want to visually observe the perineum when you ask them to contract their pelvic floor with cueing them without really giving them any idea. Just ask them how they can do it. Now, if they've had pre-operative physiotherapy and they've been shown how to work the pelvic floor before, it makes it a lot easier at this stage to for them to connect with their pelvic floor. What you're looking for is, if you ask them to contract their pelvic floor, do they have any idea at all what to do? Do they start holding their breath? Do they contract their abdominals? Do they contract their adductors? Are they lifting their bottom off the bed? Do they do breath holding strategies? Do they increase their intra-abdominal pressure? Um, and then once you kind of figure that out, you might then see, at that point, you might then go off to try to train them to connect with their pelvic floor a bit more, give them different cues, which we'll talk about a little bit later, on how to get their pelvic floor to contract better, while breathing properly and not using overflow into more global movement muscles. I'm really interested in whether they contract the posterior pelvic floor from the anterior pelvic floor, and I'll explain why that's important. More important probably in men than in women. And then their ability to contract the pelvic floor contraction once they've been cued, both in lying, sitting, and standing. And again, with the research, it's become more apparent that we need to get people off the bed and into more functional sitting, standing, functional positions to make their pelvic floor done. So for us, it comes to assessment of the pelvic floor muscle function. Um, the gold standard is really digital rectal exam, where you insert your index or middle finger, and I think in Holland it's index finger. Personally, here in the UK, I tend to use my middle finger because I can feel more. Sometimes male pelvic floors and anal canals they're a bit longer, maybe, and you want to be in the back corner of the pelvic floor to see how it's working. So you want to feel the contraction around all surfaces of your finger once you've actually cued them to contract properly. And also, Want to assess if there's any extension of your metacarpophalangeal joints, so they're actually able to move your finger through maybe 20, 30 degrees while you feel this contraction on all sides of your finger working as a unit. In the clinic, I use a lot of real-time dynamic ultrasound imaging, transabdominal, transperineal, looking at what happens to their pelvic floor when they're not contracting but when breathing. Is their pelvic floor ascent and descent? Does it change when they breathe? What happens when they have an active pelvic floor muscle contraction? Can you see the ascent and the descent on transabdominal ultrasound? And then if you're assessing anterior translation, and it's kind of a kinking of the urethra, which I'll talk a little bit more, so that you know that they're getting full closure and that their full continence mechanism working properly. And then the good people at Maple, their biofeedback machine really helps us assess specific muscle, pelvic floor muscle contraction, looking at EMG output, and I think these. It's one of the times when Maple can be useful is providing these really specific EMG values for different pelvic floor muscles, whether they're overactive or not acting, not contracting. If you've got an incontinent patient, bladder diary is really essential, because you need to know like a record of when and how much you wee. You want to see how much, and you record this information over at least 3 days. You're choose the part of your week that you measure it in, because your weekends might be different from weekdays. So you might want to do a bladder diary on the weekend for 3 days, maybe Friday, Saturday, Sunday. You might want to do 1 week, see what happens, and you want to put in the day, the time, the type of drink or fluid, how much you've drunk, and you need a little jug to pee into, so that you can measure how much passing. And then it's like grade your urge really. Like 1 is no urge to pee, and a 5 is a strong urge to pee. So it might well be that you went to pee because you've not been for a while, and you think your bladder may feel full, although you don't have much feeling that is the case, or you're going maybe quite frequently with a strong urge, and when you get looking at, did you leak or wet yourself? How much did you leak? Did you have to change your pads? Maybe how many pads were you using? And did you pass a bowel motion? So getting that information is it kind of helps us with the whole treatment plan of are you going too often? Do you have some kind of overactive bladder kind of component to this that we have to address? But it lets us know how much fluid you're having in and how much fluid you have. See. So exercise prescription for urinary incontinence. Really what we're doing is we're bringing the function of the pelvic floor, which usually happens in the background, quite automatically without us really being connected to it, and we want to teach volitional pelvic floor contraction. Now, ultimately, we are really hoping to get back to the automatic function of the pelvic floor. We don't want it to be something that is in our thinking about every time we move and every time we stand up or squat or have sex or whatever it is we're going to do functionally. And we want to really look at volitional contractions in crook lying, sitting and standing. Now it might well be, I personally want to get my male patients, sitting and standing up as soon as I can, mainly because the literature will support that, and I'll talk a little bit more about that later on. But really we want to assess the repetition maximum by asking the patient to perform the maximum voluntary contractions. We have this kind of idea, I think, that we get everyone to do 10 contractions, but some guys, especially at the very beginning of the rehab, might be actually fatiguing at 4 or 5 contractions. So asking them to do 6 more is not a very effective way of driving their strength training. And also, if we look at strength and conditioning principles, that's not what we would do. If you could do 6 bicep curls, and then at the end of 6 biceps curls, the next 4 where you were extending your spine, you were throwing the weight around, you wouldn't encourage that patient to do those last 4, because they're not going to be very effective when you become muscle building or muscle strength building, morphology building, as if you do like a poorly controlled, poorly executed exercise. So one of the things I do in the clinic is I assess the maximum number via a digital rectal exam. So I want to feel when they contract around my finger, how many maximum contractions they get before actually they stop being able to do a maximum contraction. And that's their repetition maximum for me. I will then, and if I don't use a digital rectal exam, because I don't do that with everyone, I might use some dynamic ultrasound imaging, and I'll see how much they can elevate and the ascend and the descend of the pylorus, and decide from that when they stop being able to lift and relax. And I'll start at that level. So if it's 4, if it's 6, or it's 8, it'll be different for every person. So it's very customized. And then I would want to see if they can do the same thing. If that's in crook lying, because gravity is eliminated and it's a bit easier, I'd then want them to sit, or I'd even want them to stand, and I would try to see if their maximum is still the same, and I would work them in the most gravity dependent position that I can. This paper is a scoping review. It was published last year, end of last year, by Jacqueline Santos. They did 24 studies. They looked at a number of different protocols. The most frequent recommendations were 3 sessions per day, with a frequency of 6 to 15 contractions performed in lying, sitting, or standing. What they found was there often was a focus on the anal sphincter or the bulbocavernosus muscle, or both. They also found there was no consensus on the start of protocol, treatment duration, so when you started the exercises, when the treatment, contraction or relaxation time of the muscle, or the intensity of the force of contraction. So what they came to the conclusion was that we need a big consensus. We need way more research to actually figure out what the guidelines are to clearly define training parameters. And we have some of those already from some individual researchers, but when we actually start to look at trying to get some cohesion between people globally, everyone's doing something slightly. There was this paper in 2020 which I quite liked because it was a retrospective chart review of 136 patients, categorized as having overactive or underactive pelvic floor and mixed pelvic floor function. Patients with this mixed pelvic floor dysfunction were instructed in down training and then strengthening. They looked at pad usage because they're looking at incontinence. They looked at per day. They looked at pain scales, and the results included decreased pad usage and decreased pelvic pain, and increased pelvic floor muscle strength, even in patients who received primarily relaxation training, which was interesting. But the point about this whole study was that individualized care is important really to get best results. So treat the person that's in front of you. Research is absolutely important, but reality, the person that's standing there in front of you asking you to help them is also important. This paper was by Paul Hodges et al. In 2020, and it was this idea that men's pelvic floors work differently to get continence than women. And we wanted, he was saying that most of the studies looking at incontinence really include women, and that limits our extrapolation to men. Urethral pressure in men is created by circumferential internal urethral sphincter, smooth muscle, pelvic floor muscle, skeletal, mucosal walls, urethral vasculature, and then contributions from levator ani and bulbocavernosus. Now, urethral pressure is interrupted by prostate surgery, and Paul Hodges was really saying here that the anterior continence mechanism should be the focus, not the anal contraction. What I kind of feel is that probably they are both important. I think they need to work. I think they need to work independently of each other as well as together. And so in the training that I do with my guys, I tend to do anterior training, posterior training, and then combined training. I use they're proposing that transperineal ultrasound should be used to assess the correctness of contraction, because you can see the anterior translation of the urethra and a slight kinking pattern that happens with bulbous spongiosis against levator ani. They also encouraged intra-abdominal pressure management to be part of the program, and the thing that I feel we're probably maybe missing a lot in post-prostatectomy rehab is this integration of the pelvic floor muscle into functional tasks, and also this encouragement of adherence to a consistent home. So this paper in 2019 was by my good friend and colleague Joe Milios, looked at pelvic floor muscle training and radical prostatectomy, a randomized controlled trial. And Joe's paper really influenced the way me to change how I treat my patients. But what she did was she had participants were divided into two groups. An intervention group that received supervised powerful floor muscle training and a control group that did not receive training. The training protocol exercises looked at strengthening and endurance. Assessments were conducted at 2, 6 and 12 weeks post-surgery. And what we found was with pelvic floor muscle function, the intervention group had a greater improvement in pelvic floor muscle function. And she assessed it with two little tests that she developed, a rapid response test, how quickly you could do these, how many you can do in a certain time, and then a sustained endurance test, how long you can keep a squeeze hold for. The urinary incontinence intervention group experienced faster return to continence, and by 12 weeks post-surgery, a higher percentage of men in the intervention group had regained urinary incontinence compared to those in the control group. So on the back of this, I've kind of like developed Joe's protocol into my clinic. And I just wanted to kind of like highlight some of the things that she says and what she puts in practice in her own in Australia. So the pelvic floor exercises are best taught pre-op. So if you can see your guys pre-op 100%, that makes life so much easier for you. Exercising can begin once the catheter is removed. Interestingly enough, there hasn't really been a study looking at what would happen if you started the exercises when the catheter is in place. So at the moment, we follow best practice, and best practice is that you do the exercises once they're removed. However, if you teach somebody to do pre-op pelvic floor exercises, you pretty much can be certain that during the post-op period, they're having a little squeeze just to see what it feels like. Joe Melios, 2020, came up with a list of best instructions to get a bloke to contract the pelvic floor, so tighten the muscles of the urethra like you're stopping the flow of urine. This squeeze activates bulbar cavernosus, ischiocavernosus as well, to compress the bulb of the urethra. Or draw your testes up inside the pelvis, retract to shorten the penis. Nuts to guts was an Australian one. This activates the striated urethral sphincter and pulls the urethra posterior. You gently tighten the muscles around the anus, and that's puborectalis, and it pulls the urethra anterior and elevates the bladder neck. So these things all have a function that we can see on real side. So Joe Melios research protocols from her study that she produced. She did prehab, which is 5 weeks pre-radical prostatectomy is optimal. High intensity pelvic floor protocols, recruitment and standing. And what she felt that the high intensity, so doing maximum voluntary contractions and then endurance work, was the best for continence recovery, because 50% of her group had less leakage for half as long as the control group. Now, erectile function is another thing we need to consider, but it takes a minimum of 3 to 4 months to impact. And I think you can still be looking at erectile function 8 months, 9 months, maybe 15, 18 months down the road, because it can take quite a while depending on the amount of nerve damage or tissue damage that happens during the surgery. So you're looking at 6 sets of pelvic floor muscle contractions per day, 10 fast, 10 slow, so it's 120 contractions per day in standing. So it's quite a lot of contractions, it's a big commitment, and the guys do have to see some improvement in this to be committed to it, I think. Rapid response test is 10 contractions as fast as possible each time, and then the sustained endurance test was a timed hold up to 60 seconds of maximum contraction to see if they can do the 60 seconds or do they let go of that contraction before that. So some of Joe's pointers on continence and muscle function. Men are always dry at night first. They're usually okay in sitting. They leak sit to stand because usually either the muscle coordination or timing for contraction isn't quick enough, or their intra-abdominal pressure increases. That means the pressure in their bladder is greater than the pressure in the urethra quickly, and they can't account for that. They can't make that pressure less, and so they leak. You want to do too early training, and then increase to initially, and certainly at the very beginning of rehab, they might not be able to do 10 contractions. They might, as I said, they might be at 3 or 4. So they might be doing little and often, and then increase that to 3 or 4 either maybe at like a month or 6 weeks down the road. If they have started super weak, sometimes the weakness is is actually caused by pain inhibition or a lack of brain pelvic floor connection. And once you change that, that means they actually improve their strength quicker because you're actually increasing the kind of neural connection between their brain and what's happening with the pelvic. One of the things that the guys hate is this: they go for a pee, and once they finish peeing, they have this post-void dribble. And Joe uses a kind of an idea to do little rapid contractions, little rapid short penile lifts at the end of voiding to help, if you like, almost massage the urine out of the urethra. Remember, alcohol is an aggravating factor, and the pelvic floor weakens with age. So if we're looking at older people, it doesn't mean to say that you can't strengthen it, because muscles in the older population can still strengthen. They can still build strength, build morphology, and there's no evidence that although we do get weak as we get older, it tends to be because of reduced activity. So it is definitely a use it or lose it phenomenon. So Joe says it's never too late to commence pelvic floor muscle training. Continue the rehab for 12 months because of if you've got a neuropraxic effect or a damaged nerve effect, it can take up to that time for neuropraxic nerves to recover. Definitely a thing that's close to my heart is add functional training as soon as you can. Get these guys gravity dependent, standing, walking, jogging, running up hills, so walking up hills, walking in rough terrain. I really like functional loading for these guys, to teach them to control their pressure system and to load their pelvic floor with a volitional contraction so that we can work towards that becoming automatic. So squats, curl ups, Turkish get ups. To be honest, functional exercises are whatever they will do. If they are a gym going patient, I had a patient recently who was jiu-jitsu, a young guy, 49, and 16 weeks. He was super fit before he came pre-op. He started his exercise very quickly. He was very compliant, and at 16 weeks he was completely dry, and he had full erectile function back. He had a radical prostatectomy with nerve sparing, but it wasn't robotic. It was done just freehand, and the outcome was incredibly good. But it was partly his commitment, his pre-op condition as well, and the fact that he was probably a little bit younger. His muscles maybe got stronger a little bit faster. Joe would say wean off night pads first before day pads, and that tends to be the case. That tends to be what happens, and they tend to do that themselves. You can use a penile clamp temporarily, so you get this little clamp that you can put over the urethra that squishes it flat for things like going to the gym or going out in the evenings, but only if you've got like a high pad use during the day, or you find that the leakage is at the high end of continence. The penile clamp can sometimes help build bladder volume capacity, so it gets the bladder comfortable about being stretched before and maybe reduce the risk of frequency or urgency. And also maybe as the bladder gets heavy and you're keeping more urine in it, you maybe get some pelvic floor muscle hypertrophy because they're working against a bit of resistance. The two clamps that I'll use in the UK are a Weisner clamp or a Pacey cuff, and it depends really on which one the patient prefers, which one will have. I think be aware of bladder irritants, caffeine, alcohol. Beer is also the worst, maybe because of the yeast or the sugar that's in it. I sometimes say to my patients, try and get a beer that has the sugar fermented out of it, so like a Pilsner, because they are going to have a beer, so you might as well give them some advice about what the best one is. For some people, food irritants, MSG, spices, tomato, chili, those things can make you more incontinent and make you go to the toilet more. So it's worthwhile mentioning them. There's not massive amounts of evidence that have a direct connection, but it's worthwhile saying it. So Joe's pad wearing protocol is, she often finds that pants or pull-ups are not necessary. In the cohort of patients that I tend to see in the clinic, I often see guys that are quite far down the line and maybe they've not been doing their exercises in the most efficient way, or they've maybe been instructed incorrectly, or maybe they haven't been scanned or assessed to see exactly when they're doing the proper contraction, if you like, what's actually happening. So they often are, by that point, maybe are in pull-ups or incontinence pants, but the kind of idea is that you'd want to get rid of the nighttime pads by the second day or as soon as you possibly can. Or you want them, if they're on pull-ups, you want them into pads, by day 2. You want them out of their pull-up pants. You want a tenor or a Depend Shield, which is a much smaller pad at night. If they get three dry nights in a row, then ask them to discard it. When they get up in the morning, if they can manage to get up, have a shower, get dressed, walk downstairs without a pad in, maybe put it in before they go have breakfast, so they're having this little time when they've got underwear on and they're not leaking, just to show them that can happen. However, if they are leaking, then they don't want to be wet, so pads in place are essential. So you wear a pad if they're out, if they're exercising or work only. So if they're around the house, I tend to encourage them. If they're not, if they're leaking, if they're managing to, encourage them to hold to get to the toilet, to become more aware that they need to go. You can do things like progressing it, where you can do no pad in the morning. So these are after a few weeks. So it's kind of like, maybe a month and another month, and you're trying to reduce their dependence on the pads. They can use like a shield, which is more like a thin liner if they're out socially, or if they're going to have a beer in the house. And maybe then what eventually happens is, when they don't need a pad and they're dry, they stick a shield in their pocket purely for psychological support. Joe has this clamp wearing protocol that not every patient tolerates a clamp, and for sure it can squish your urethra together, and it can sometimes make things feel quite uncomfortable. And it's kind of really for excessive leakage. If you're using more than 4 pads per 24 hours, which have got more than 300, they're way more than 300 grams. Maybe social outings, physical work, exercise, where during the day you can have them on. It says for 2 hours minimum, but to be honest, you can put them on for as little as you want, I think. You want to at least have a day without them on, because there's quite a lot of compression in the tissue, and we don't know what the effect is going to be on urethral tissue. There doesn't seem to be that much out there talking about negative effects. The maximum usage is usually 4 hours at a time, and you wean off the clamp as with weaning off pads. So this was an interesting paper in 2018. It's a little old now, but it looked at the effects of progressive resistance training on post-surgical incontinence men with prostate cancer. So if you've got a guy that loves going to the gym, then getting him back there as soon as you can, based on the study, would be a valuable thing to do. We've got 59 patients after a radical prostatectomy were instructed in resistance training within 2 weeks post-op and continued for 12 weeks. They looked at urethral closed pressure, maximum cytometric capacity, and detrusor pressure at maximum urinary flow. Kegel exercises were focused on 0 to 6 weeks, then elastic band-based high-speed land resistance exercises for 6 to 12 weeks. And at 12 weeks, to 58 or to 0.5% has achieved pad-free status. Now, we're not. This paper doesn't actually prove that resistance training does this, because a lot of these guys are probably their volitional pelvic floor contraction is getting better anyway. But they looked at changes in hip extensor muscle strength was an independent predictor of continence status. They didn't really see any meaningful changes in the exercise group. I wanted just to have a quick mention about Maple in the clinic. Because I see a lot of guys who are quite far down the road on their post-prostatectomy journey recovery, Maple can be really useful, I think, because it's this precise assessment of pelvic floor muscles. It kind of, if you've got somebody that comes in and they've been doing Kegels for a long time, and they're not sure they're doing them right, you're not sure exactly what they're doing, Maple gives us this targeted feedback. Really, it gives us this real-time, multi-channel feedback of a specific pelvic floor muscle EMG. It can show us differentiation of muscle activation. Is there more activation on one side than on the other? Is there weakness there? Is there distinguished between the superficial and deep muscle layers? And then also, is there areas of weakness or overactivity? Because overactive muscles aren't necessarily strong, and they need to be down-trained and then built back up, which is what we maybe spend our time doing. And maybe that's why these guys, 8-9 months down the road, are still using 4 or 5 pads a day, or maybe leaking quite a bit. And then it helps us get them back to more functional loading in a much quicker way. The other thing I find Maple really good for is to treat these guys in weight bearing in the standing position with functional movements, which can really help bring them on. I think they like the real-time visual biofeedback. They're able to see their muscle activity during exercises, especially blokes love a gadget, and the biofeedback is a really powerful tool for them to refine their technique I would say, for a more effective contraction and maybe for a more focused contraction. I really find that it's useful when the usual protocols that I put in place haven't worked. Also, if you have somebody that might well be is still maybe incontinent at 8-9 months down the road and might be a candidate for going back to the surgeon to think about external useful sphincter replacement, then you can spend a lot of time trying to get these guys stronger, and that's not going to happen. So they're going to their sphincter is damaged and it's not going to contract again, and they're a candidate to have an artificial sphincter put in place. I find Maple it saves some time because it can let us know that there's no improvement seen over a few weeks with a focused program. Then you can send them back to the consultant saying, look, I really think this guy is a candidate for urethral sphincter replacement. So I think that it helps you customize the exercise programs, and there's also this empowerment engagement that that is more interactive and more goal orientated. And I think sometimes my guys, because they've been at this for quite a long time, they think they're not getting any better, and Maple for me can really get some of these, turn them around and get them back onto a much more functional training. Okay, so I think I'll stop and I'll see if you have any questions. Thank you very much. I think I kind of zoomed through that. I hope that wasn't too fast with my Scottish accent and my English. Does anyone have any questions they want to ask? I don't know if there are, if there's anything in the chat. No, I don't think so. Do you guys all, are you all seeing male patients in your clinic? Yep. Yep. Good. Excellent. Anything that you agree with or anything you disagree with, anything you've got to say? I'm interested to hear what other people are doing. Yeah. Hi, Elizabeth.
Hi, could I just ask a question about the erectile dysfunction side of things? In terms of, is there anything else that you get guys to do after having it done, other than what you've talked about already?
Sorry, what did you say?
Sorry. Oh, can you hear me?
Yeah, I can. Yeah, I can.
Oh, sorry. Is just anything else in terms of specific with what the research says about the erectile dysfunction from a physio perspective, other than what you've talked about already?
Right. So, from an erectile dysfunction point of view, yeah. So, what would I say about that? So the erectile dysfunction recovery it's really interesting. So most of the research looks at most guys that have had prostatectomies in the past have been a bit in the older age group, maybe 70 and above. And what's happening is we're seeing more and more younger guys come through the clinics with so I've, like 49 was the guy I spoke about, and I've had lots of 50-year-olds, and I think my feeling, so yeah, so from an erectile dysfunction point of view, what I have a lot of functional stuff that I do. So the thing I feel about so I think that I absolutely like to get, from a urinary incontinence point of view, I like them to be standing up. So from an ED point of view, I like them to be doing the things that look like sex.
Yeah.
So I actually like them to be doing hip extension, resisted hip extension exercise programs, loaded. I like them to be doing resisted programs with strong band resistance. I like them to be doing, I even do, so these guys as well, they'll be using usually a penile pump.
Yeah.
The penile pump is really handy to add resistance in to work the pelvic floor muscle. So I've started doing this thing recently where it sounds a bit weird, right? And they do think I'm a bit nuts, but they put the penile pump will, especially if they've got it with quite a lot of blood in their penis, it actually makes their penis quite heavy. So what I'll get them to do is to go onto all fours with the penis pump in place, and I will get them to do their other anterior pelvic floor contractions against the resistance of the weight of the pump.
Yeah, that makes sense.
And then the other thing I've been doing is sometimes they have that one side is weaker than the other, and when you scan them, you see there's this imbalance from one side to the other. So what I'll do is I would get them to do lie on the side. So let's say their right side is weak. I'll get them to put the pump on, pump it up, lie on their left side, take their underwear off, and let the whole thing dangle.
Hmm.
So when they're doing the contraction, there's a focus towards the right hand side that lifts the penis pump up. And actually, so they're lifting against resistance. A bit like if you had biceps weaker on one side, you would maybe
Yeah.
do, and I might do more contractions on that. I would just apply strength and conditioning principles to that. Um, and then once they do that, I then get them standing up doing hip thrusting with like thick bands.
Yeah.
Then, if that's okay, I then see if they can get an erection in standing, and once they've got their erection in standing, can they then thrust against resistance?
Yeah.
So so get them to do what do you normally do, like during sex? What position are you in? If you go back to different positions, if they're normally in kind of a missionary position, then planks are good for them
Hmm.
with erections, and I'll do planks with erections with the pump. So I'll incorporate the time they use the pump as part of the resistance training.
Yeah.
So that's kind of the functional stuff. And I think it can be. I then on top of that, because there's the evidence about pelvic floor muscle function being better with general exercise. Get them in the gym, get them doing some loading. If they won't
Hmm.
go to the gym, you can get them to load up backpacks at home,
Yeah.
doing squats, deadlifts, lunges, all of that kind of functional stuff, as well as because there's a big cardiovascular component to erectile dysfunction. And I know, it's in the group of people that are not post prostatectomy that they just got ED for some other reason, for some kind of vascular reason. So I like to get them back to some form of cardiovascular activity. And it's really whatever they prefer, running, swimming,
Hmm.
whatever they want to do, something in the gym.
Yeah.
Um, and that, I suppose there's that, and I suppose there's the lifestyle kind of things. How much do you drink? Are you smoking? All of that. Do you have diabetes? Is that well controlled? So all of those things that you would think about, yeah, for sure.
Yeah, thank you. The reason that I ask is that I'm based down in Kent,
Yeah,
and there's a group of four of us, and we see loads of routes in our NHS clinic, and we do really, really well with the urinary incontinence side of
yeah,
things, and we struggle with the ED side because the urology team basically say to us, we don't want you doing anything. We don't want them touching. We don't want them using pumps. If we get to their 6-month review and they've still got ED, we will refer them to our clinic, and we will manage them there. And we're kind of like, we're looking at all the research and we're thinking, well, hang on a minute, I feel like there's a lot we can do
yeah,
before then. And so we feel like this in this place in the middle where patients are coming to us and saying, look, I've read this and I've read this, and I'm
yeah,
like,
yeah,
I
yeah,
totally agree with you.
yeah,
What do we do?
yeah.
It's so hard.
I mean, I mean, Joe Milios's paper on ED and her
Yeah.
protocol for that is, I mean, it's a great paper. It actually just really clearly says if you do this, they get better.
Yeah.
Uh, and I think my experiences, I probably have, yeah. I mean, I suppose I'm quite lucky because the urologists send them to me and say, I don't know what to do with them. You just do.
Okay.
You just
Yeah.
do what you do with them. And obviously, there's a kind of ED's complex because of the whole biopsychosocial thing and the fact
Mm.
that if it doesn't work, they get anxiety, and anxiety creates, like stress, and then that means that they don't feel very sexy, and then their brain shuts down, and if you look, there's lots of, so again, it's a difficult one. I mean, I suppose what I suppose what I did was I went to the urology because they have like a little special interest group, and I just went and did a presentation, and I said, so
Mm.
here's the evidence.
Yeah.
This is what I want to tell you. And what we did was one of the guys, Prof. McNeil at the uni, I said to him, why don't you send me half a dozen patients and let's see how we get on with them. Let's see if because I think the earlier you can treat them, the better. The sooner you can get these guys on pumps, the better.
Hmm.
The sooner you can, you know, I think if you wait further down the track, then it's actually it's harder to get them to use their muscles. It's harder to they think they're not going to get any recovery, and also the pumps are really useful from a kind of like a housekeeping tissue kind of stretching point of view, so that, you know, because neuropraxia, peripheral neuropathy, if that's happened during the surgery, that can take quite a while to come back. So you want to make sure that that tissue is stretched enough and being full of blood enough, so that it actually everything is still keeping its extensibility for when the erections start to come back, I think. It's a shame that they won't do that, because I don't really, because just waiting for 6 months is kind of, you're kind of losing that initial time. I actually feel it's really interesting. So I think my guys that talk to me about this, I feel that the work I do in the first 6 months is almost probably more important than the stuff that I do when the erections start to come back. It's like I've always done all the prep work that then allows their body to just heal and recover. So there's some guys, there is some papers coming out quite soon. I think Joe's doing some other stuff looking at more kind of long-term functional stuff. So, and also because the big thing is really, I think that's missing is functional training. And I think even in 1990, Grace Dory's paper on ED and pelvic floor muscles, she didn't have a big number of patients, but actually it was quite clear that and she was just giving them simple pelvic floor Kegel exercises. And we now know that, you know, especially if we change the way that we cue them to do anterior pelvic floor bulbospongiosis, ischiocavernosis, you get that's one of the keys for me to get them back to a more functional kind of place. Really, it's a shame. I mean, like you say, there's a whole bunch of literature out there, and when you read it, you go, this doesn't make any sense, because the literature is definitely, we need more, but the stuff that's out there says we should definitely be seeing them pre-op, and actually, and that's a shame, because I remember, you know, it's a bit like, I mean, I'm quite an old physiotherapist, so I remember doing pre-op, pre-arthroscopic surgery, like stuff on people's quads, and the difference was phenomenal, really. It meant that you went in to see them, they knew what they were meant to do and they could do it. So these guys, my guys who I've seen pre-op, who then come to see me post-op, they just fly. They just do so well. And you're right. I think, and my feeling is, if we're getting really good results, like you say, with the incontinence guys, we're not that far away from what that needs to do for erectile function.
You did, yeah.
It's
Thank you very much.
It's not that far.
No, thank you very much. I've got to shoot. I've got a 10 o'clock patient that I'm so late for, but thank you very much for that, Bill.
Thanks. Nice to see you.
Bye-bye.
Yeah,
Bye.
thank you.
Okay, guys, listen, thanks for coming along.
Thank you.
Okay, take care. Bye-bye.
Yeah, thank you. Thank you.
Bye-bye.